Okay, great. Thank you so much. So I'm going to share my screen and do a PowerPoint presentation. Um, okay, here we go. No. Okay. Um, just let me know if you, sorry, let me stop sharing. Every time this is a bit, okay, I'm going to try this again.
You had it working there for a
Did I?
second.
Okay.
Yes. Yeah, whatever you did, yeah, there, if you
Okay,
want to do the
perfect.
full screen how you had it, it was
Okay.
fine. Yeah.
It was fine.
Yeah.
Okay.
Enter full screen mode there. Yeah,
Okay.
perfect.
Perfect. Okay. The problem is I can't see my notes. So I have a hard time trying to navigate that. But that's okay. All right. So I've been leading a program for rural perinatal mental health out of the South Shore of Nova Scotia since 2022. It started as well, it still is a quality initiative, and we're trying to get to the place of spreading and scaling, and it's been challenging, um, only because I've done this whole program in by myself, and I think things can move a lot faster when you're by yourself. Okay. So I usually share these quotes at the end of the presentation, but I think they deserve to be sort of highlighted at the beginning, just to give you context. So some of the quotes from patients I've supported through this program. I want you to know that the immense relief that both my husband and I felt after our appointment with you, it felt like a weight was lifted from our shoulders. I really have high hopes that this is it. This is the time we are going to get in front of the right people to get a proper diagnosis and treatment for Joel. I knew the Perinatal Mental Health Navigator had my back, regardless of what came next. She was the only constant feature in my medical team, but she was all I needed. I really can't say enough about how you helped me, and I truly believe this would have been a very different 9 months for me had I not had you and your support. And then from the community of doctors that I work with, this role also bridges the widening gap between acute care, primary care, mental health services, addressing the needs of the client while symptoms are mild to moderate, and prioritizing early intervention can prevent long-term impacts and requirements for more intensive treatment and support. And then from our local psychiatrist, I believe this role is very necessary and will save lives. So, just to start from the beginning, what is perinatal mental health? Just like physical health, it's important for your entire well being. And perinatal mental health disorders are mental health disorders occurring in the perinatal period. So, anytime in pregnancy and commonly known as up until the end of the first year postpartum. It is the most common complication of pregnancy. And when I say that, we'll show in another slide. So other complications would include like gestational diabetes and hypertension. Um, Perinatal mental health disorders occur more often than that. So one of the primary gaps is that we don't have any national guidelines. Canada is one of the only high income countries without national guidelines. So a lot of the research for this program came out of the US, out of the UK, and Australia. So here is sort of a visual of how we've prioritized perinatal mental health in this country. So we know about gestational hypertension disorders in pregnancy and gestational diabetes. Those occur from 5 to 10% of the perinatal population. We have very strict guidelines on screening, treating, referring. We have community resources that are available to patients throughout their pregnancy. And then you see that perinatal anxiety and depression on the right-hand side occur anywhere from 16 to 23% across the country. And without any national guidelines, there's just no routine standards of care that have been developed. And to put it into context, so the WHO, World Health Organization, reports globally that in developed countries, the rates are 10 to 13% experiencing perinatal anxiety disorders and depression. In Canada, our rates are 23%. In Nova Scotia, our rates are 32%. And on the South Shore, RCP included the perinatal anxiety in their audit, and those rates are 40%. Gap number 2, racialization and marginalization. So there's been some studies done by an article, the author is DeRoche, and that was in 2023 that was published, where the people receiving care are typically white, higher socioeconomic class, so they had extended benefits to afford counseling, and those that are mild to moderate in severity. And then those not receiving care included people who are racialized, people in the LGBTQ plus category, and then people who feared that their child would be apprehended if they said anything about their mental health. So the stigmas and stereotypes are alive and well in this population. Historically, societies have undervalued women and birthing people's mental health struggles. So this quote here by a psychiatrist was a couple months ago reported to me by the patient that they were told as soon as your baby is born, you'll be over the moon. You'll have nothing to worry about. And then they were declined medication prescriptions based on that way of knowing and that discourse that having a baby will fix your problems. So she didn't get the care she needed, and that was the barrier was the healthcare provider. What we know from studies out of the UK is that it's more costly to not treat perinatal mental health and because of long-term effects to the mother and the child. So once the UK established national guidelines for themselves, they reported a reduction from, if we convert it into Canadian dollars, every mother and child dyad with untreated perinatal mental health disorders cost the system $150,000. And then with screening and treatment, it was reduced to $5,000. So the third gap, major gap, is that Nova Scotia has poor communication and transportation infrastructure. Half of the population of Nova Scotia lives rurally, and often people are struggling to find cell service, internet capabilities, and transportation. So there's no public transportation that links communities together from rural Nova Scotia into urban centers. And a lot of people lack their own transportation. So this is my story and how I came to do this program. Um, this quote here, the first to help you are the ones who know how it feels to fall down. So I've been a nurse for over 17 years across Canada in rural and remote hospitals. And I went through IVF twice and I had a successful transfer. I have a daughter now who's 5. I also experienced miscarriages, several of them after her birth, and anxiety and depression postpartum. Actually, throughout IVF into postpartum period. So I was a healthcare provider. All of my friends were my colleagues, essentially, around me. I held my tears in when my midwife came to assess me at my home. I phoned the floor to see if I could take something for sleep, and they didn't quite understand why my husband was asleep, my baby was asleep, but I couldn't sleep. And it wasn't until a year later that somebody expressed that they were worried about me, and I felt I was overwhelmed with anger and resentment because nobody knew how to talk to me about it or how to help or what questions to ask. Um, so I obviously I'm not alone. If 40% of our perinatal population is reporting anxiety, so I educated myself in perinatal mental health through Postpartum Support International and realized I could do something. So where I started was a needs assessment because I didn't want this program to reflect only my needs. um, I went to the reproductive mental health program and kind of shared my experience, shared my ideas, and they agreed that they have limited capacity. They treat moderate to severe cases. They have strict entry guidelines or inclusion guidelines and strict exclusion guidelines. Their wait times are up to 3 months, and they explicitly express that they need rural communities to have the capacity to treat perinatal mental health. They can't be seen as the be all end all. Healthcare providers in my community on the South Shore were also frustrated with the referral process to the reproductive health program, stating that referrals were being sent back or declined. So then this led to them wondering why they should be screening their patients, because if there wasn't, um, a clear referral pathway or something to do with them next, then why screen? So that led to low confidence. And then the perinatal population. So if they got into reproductive mental health, we're waiting up to 3 months or up to 6 months through the Adult Mental Health and Addictions Provincial Program. So their mental health care providers, they reported, weren't talking to them about mental health. About half of the people surveyed reported that. And they were unaware of resources that were available for perinatal mental health specifically. So that is what I'm where I started in my development of the Perinatal Mental Health Navigator, was how to respond to those gaps. Um, a navigator historically and through studies has been seen as a cost-effective measure. Um, it's accessible, so I needed it to be accessible to anyone in rural Nova Scotia, and the best way for that was through telephone calls, texts, and email. And it addresses infant mental health simply because we're helping the mother's mental health. It also works off of best practices that I've gathered from BC's reproductive care program and the UK's NICE guidelines on perinatal mental health screening and treatment. Also the framework for the navigator has been taken from literature reviews of navigator positions throughout the US. And what I think is important for this population is it puts their stories at the forefront of their care, by way of the navigator doing a history, summarizing it, and providing it to all of the care providers in their circle of care. So this is just a framework or a logic model of this program from start to finish of a an interaction with a navigator. It starts with having that RN, and it's specifically RN because, um, well, I am an RN and I've based it off of what I know of being a nurse. And it also includes creating a care pathway and initiating treatment for perinatal mental health disorders. The cost would be to pay that RN and then a one-time uh, purchase of computer and cell phone and all the accessories needed to carry out seeing a patient. Clerical support is ideal as well if you have it. And so it requires perinatal care providers to screen. And simply by adding a navigator into a site increases the screening rates because now they have a care pathway. They have a referral pathway. If their patients screen positive or screen high, or even just report that they are having struggles. So it requires the screening and the conversations. And it's anytime in pregnancy up to the end of the first year postpartum is when referrals can be received. Uh, then they make out a referral for the navigator. A patient can also self-refer. There's a poster up at our Family Resource Center for patients to phone or email. And then the navigator gets in touch with the family and begins supporting them by gathering by telephone, text, and email. So the activities that go on during the support cycle, initially there's that biopsychosocial history and care plan that are developed to guide services and check-ins. And that model of biopsychosocial history has come from different documents created in Nova Scotia, the provider's mental health toolkit and the maternal mental health toolkit. Um, so yeah, I develop a nursing care plan and then distribute that amongst all the care providers. We identify the needs and goals and follow up on any referrals that physicians have sent or that I have sent to make sure that the referral pathways um, are clear and that the referee has received it and the patient's responded back. Because we all know how difficult it is to sometimes get in touch with people in the postpartum period, especially. There's service mapping and referring families to things like tranquility and also local psychiatry. Then we revisit goals and update the care plan. There's screening and determining severity of symptoms. And then the treatment that a nurse can initiate that are validated for the perinatal mental health population is psychoeducation, mindfulness techniques, and motivational interviewing. I've also taken extra training in cognitive behavioral therapy and interpersonal psychotherapy so that I can use those tools. But in connecting patients with peer support, these are all evidence-based treatments, and we're doing this early on in their pregnancy. Then a patient can exit the program when they have a finite treatment plan established. So whether that's connecting with a counselor in the end, or a psychiatrist, or a peer support group, and they're feeling satisfied with that service, or if symptoms are relieved simply by interacting with the navigator, or the patient often disengages sometimes. So what this means is that 20 to 25% of our perinatal population have been referred to the navigator from like from the first month up until now. That's been a consistent number that myself that I've been following for my area. And now that many people are receiving evidence-based treatment. So the actual outcomes of this program are on the left. That wait times for psychiatry have been reduced to 2 weeks. How did I do that? There seems to be like at least one psychiatrist in a community that is passionate about perinatal mental health, and I've developed relationships with those psychiatrists, and so I'm able to, like, and they trust what I'm doing, so I'm able to write them the letter of referral, and their office gets in touch with the patient. So we've created a new referral pathway and reduced the wait times. Then the improved care provider satisfaction, meaning that they have a referral pathway now for their patients. We now see that patients are screened 100% of the time in the prenatal period at least once, and more often if they've screened high. And then evidence-based treatment is now reaching 25% of our perinatal population, starting as early as the first trimester in pregnancy. And then through surveys of patients, 80% who responded reported that their symptoms were relieved with interactions with the navigator alone. And 90% of those that received the service were satisfied with it. From this, we're hoping to see other changes to this population. For example, reduced chronic depression. The reduction in these pregnancy complications is predicted because perinatal mental health can lead to higher rates of these things. So if we're treating them early, perhaps we can reduce risks of preterm birth, fetal growth restriction, preeclampsia, peripartum hemorrhage, placental abruption, and stillbirth. And then we know that addressing maternal mental health is going to improve their infant bonding and feeding and attachment. So this can protect against ADHD, autism, cognitive behavioral problems. So very long-term goals are reducing death by suicide. Death by suicide is the fourth leading cause of maternal death. And then, this, if we do achieve to some degree improvements in population health, that'll reduce the healthcare burden and save money for the system. So just to recap, the RN Perinatal Mental Health Navigator can be looked at as an adjunct to the reproductive mental health services to support perinatal families and healthcare providers to increase capacity and improve access to mental health services for the perinatal population in rural Nova Scotia. It's a run-on sentence, but it captures everything. Perinatal mental health is the most common complication of pregnancy, and a patient navigator is integral to a patient's circle of care, and that is to assess, treat, and follow up in a timely and effective manner. This leads to universal mental health care, creates solutions for Nova Scotia's Action for Health, and has the potential to save hundreds of thousands of dollars, if not lives. So if anybody's interested in resources that I've used for some of my statistics, it's listed here. And or if you're interested in having a copy of this, I'm more than happy to share with everybody.
Thank you so much, Crystal. That was an amazing presentation because I didn't even know your role existed. So you're quite the pioneer. Also, I should tell people that you're also one of our new students in our mental health
Yes.
addictions program.
Yeah.
So you really are a pioneer. This is amazing. And having people like yourself in our program is excellent, and I really hope we can attract more people like yourself. But I do have a question for you. So I love the idea of navigator. I think even just the word navigator has a lot of strength in it because I think it helps people understand that you're there to help them, like, lead the way, navigate,
Hmm.
because so many concerns in the navigating the health system happens, and this is a problem for those who are even proficient in
Hmm.
healthcare, and people like yourself and myself with clinical backgrounds even struggle at times to be able to sort of get around. So I can imagine how helpful it is to have this role. And I'm wondering, like, it's actually a few questions.
Yeah.
First, have you started looking at publishing or doing actual, like, it sounds like you're doing some research because you've mentioned some stats,
Yeah.
because this is really so important
Yeah.
to disseminate, especially around the validity and the importance of having these roles, because this is shouldn't be just even like they need more in the rural, but they also need in the urban because
Yeah.
it's the same kind of. And what happens to those in the postpartum then? Because if you're in that perinatal, is there another navigator for postpartum, or is
I
that
follow people up until the end of the first year postpartum.
okay?
Yeah.
Okay,
Yeah.
that's
Um,
great.
yeah. Yeah, so to start publishing, yes, I've certainly been given more tools now that I've started my master's program. The
Yeah,
program planning, that's been really helpful. Uh, I and what I struggle with right now is being alone, right?
yeah,
I'm very much alone, and that maybe this is like a cry for help to anybody here who wants who could help me in any way. I would greatly appreciate it. But yeah, I think that would be really useful as well.
yeah. So there is, definitely you have that interest. It's
Hmm.
just, and I can imagine right now, being that you're the first in this role, all the everything that goes with that is extremely time consuming. Plus, you're doing your master's and everything
Yeah.
else. So I totally appreciate that. But I think when the time's there and the resources are there, it would be fantastic to disseminate this. So thank you. This was very informative and
Great.
great work that you're doing. Does anyone have any questions or comments? And you've got quite the audience, Crystal. I'm very impressed. Amy, go ahead.
Oh, you're muted.
I was
Of
muted too, and
course,
I
of
thought
course.
you were muted.
So my name's Amy. I'm a mental health nurse, and I came to this presentation because I'm really interested in this program. I also work in rural at a rural hospital in Kentville. I'm just
Okay.
wondering how you got it, like how it all started, who you
Yeah.
applied to, who you told about, because I think it's really important to have at our hospital too.
Yeah. Um, and so I have a close connection with public health nurses because I often support them in the perinatal postpartum period. I was supporting some people in Kentville, some patients, and then I had to say, that's too much for me. Like, and I think the navigator should be into the community. Um, so there is awareness in Kentville of what I'm doing. And I think if you're an RN in the hospital, I think your manager is definitely aware. I have put a call out to other managers in the province. I've heard from uh, one from St. Martha's who's interested in spreading and scaling, and then I'll come back to that. I got started simply by writing a proposal for a grant, which I didn't get, but taking that proposal to my site lead and saying, these are the stats, this is what needs to happen, and can we do it? And they said yes. So I've been doing it. I've worked part-time on the floor, and then I've been doing this on my own time. So yeah, it's still not an official position. Um, and that's what's really frustrating for me is waiting for other people to catch on and making this a priority. So one thing that I included in this presentation is like that I have had talks with the reproductive mental health program that they are on board with this navigator role, that they see a need for it because every time I present to like provincial um, people, provincial like RCP maybe, or like the higher ups. Sorry, I can't think of the word. The people with the money, they defer back to reproductive mental health, that they want to check in with them to make sure um, that it's okay to do this, or who should be responsible for me, for the navigator. And it's just driving me nuts. So I don't know. Does that help?
Yeah, that's really great. I'll have to talk
Yeah,
to my manager about it because I know she would be really on board with it, but
yeah,
our staffing on the unit is so horrible right now, like
yeah,
everywhere else. But I'll have a chat with her and see what she said.
yeah. Kelly. Kelly.
Hi, thank you very much, Crystal. I, like Audrey, don't know anything about uh, this topic at all. I have never even had children, so that's how novice I am to all of this. But it strikes me as such a critically important role based on the data that you've provided, like the numbers that you've provided. And, when you're talking about doing this on your own and not having the support and needing to connect with people, I applaud you for that because that is so very scary and it's so very political,
Yeah,
right? And hierarchical, and all those, all that relative power that within the health system and that kind of thing. And you had talked about, talking to the reproductive care program, and I'm wondering, have you had opportunity to develop a proposal, a very short proposal
okay.
that can be with the reproductive care program, using exactly your presentation here and maybe building on a little bit more of the evidence surrounding it and reaching out to the Minister of Health?
Yeah.
Like
Yeah.
what I learned in my graduate level work, both my master's level and my PhD was, and from great supervisors was, you know what? If you're not getting any answers from the middleman, go straight to the top,
Right.
right? Like
Yeah.
reach out to the CEO, reach out to the Department of Health. And that was such valuable learning. So I don't know if you've had the opportunity to do that, but that might be something, especially with the evidence, right?
Mhm.
And being able to support that data that you have, that of the critical nature of this, right? It's
Yeah.
it's for the well-being and outcomes, and would align nicely with the Nova Scotia Department of Health and Wellness strategic plan for
Exactly.
2024. Yeah, 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 yeah,
Exactly.
yeah,
And I have, yes, but I think at different stages of my program. So I think that was a good reminder to reach back out in this stage of things.
yeah.
And as also as like just to come back to Amy, that even I am sort of a I don't know, a rebel. I don't know what you would call it, but um, even though I don't have a position, I'm still doing the work. I'm still getting paid to do it as well. That it almost takes, it has to be a priority of the person that to want to do it. Like Amy, for example, if this was passionate for you, then cut down from part-time and say, I want to do this. You know, they can't you know, I've been under I've done things and begged for forgiveness later sometimes, but you know the people who want to be the navigators have to have that drive to create it for themselves as well. Like
Absolutely.
you can't wait for the hospitals to
Every
agree.
movement requires a champion.
Yeah,
Every
yeah,
movement.
yeah,
Right? And then you build your champions because there's power in numbers.
yeah. I
And
love
you get
that.
patients and families talking about this
Yeah,
to the Department of Health to
yeah,
with your data, it's huge. It is really a huge movement. So
yeah.
yeah, good luck and kudos to you. Thank you for this.
Thank you,
Yeah.
Gail.
I so many buttons to click just to get on, but my name is Gail. I'm the clinical nurse specialist in the NICU, and this is sort of a bit of a logistical clinical question, but
Yep.
we have families from the South Shore Regional,
Mm-hmm.
and they're supported by social work in the unit, and if deemed necessary, um, there's a reproductive mental health consult done. But if it's not to the point where they need a reproductive mental health consult, but they're being transferred to home
Mm-hmm.
hospital,
Yeah.
am I able to refer to you?
Absolutely, absolutely.
Okay.
Yeah, it's very low barrier referrals.
Okay.
Even if a patient says they want somebody to talk to, if they don't disclose exactly why, then absolutely. Um, so I will, yeah, I'll put it in the comment section. I'll attach it there, I think. The referral
Okay.
form. Yeah,
Thank
so
you.
I'm really
Yeah.
glad you're here because I've tried to reach out to the IWK and I guess it's not getting, the message isn't getting to everybody.
Yeah. I think you're well connected to Jen Jollymore, who's
I am,
my
yes. Yeah.
counterpart in the birth unit. Yeah.
Yeah.
So we work really closely together. So yeah, I'd love to have
Perfect.
that referral form and just even to inform um, our team about it.
Perfect. Yeah.
Because I don't
Because
think our social workers are aware of the resource either.
yeah,
So it would be a good connect.
perfect. Thank you. Thank you.
Thank you.
Um, if may I share a few other things?
Yes, please go
Okay.
ahead.
So I've created, I'm just going to go back to uh, the internet, wherever that is. Okay, there we go. So if we go to the reproductive mental health page, this is a document that I've created. It's in the related documents section. It's a care provider pathway for mental health and addictions. So this is an extensive document that this is the cover page as sort of a summary, but it has a lot of resources in here for how what education you can provide a patient, how resources for sleep, self-care for the patient. There's a patient pamphlet that I've created, links to community supports that can be accessed throughout the province. There's also family violence, substance use, birth trauma, LGBTQ, and Mi'kmaq resources. And so you just can click on the different highlighted areas and it'll take you to, for example, education. I put some points in here about the different things that you could educate a patient about. The nests is self-care, and it's here. So anyways, this is available for anybody who's interested. There's also this document that I've created, How Anxiety and Your Mood May Change in Pregnancy and After Birth. It's a long title, but it's kind of what it is. And it's just providing some information on sleep troubles, intrusive thoughts, common disorders like, or common problems such as baby blues, and then gives you it's like self-assessments for anxiety and mood disorders, and then some information on postpartum psychosis. If you use any of these, please feel free to give feedback to me because I do constantly update them. Yeah, so I just wanted to share that as well. Any other questions? Oh, yep, Mary.
Hi, Crystal. Thank you so
Hi.
much for your presentation and for sharing your own story as well. I just had a question around I guess logistics as well. Like if you mentioned one FTE nurse role for this, like do you have an idea of how many patients that one FTE would serve, or if you already had a nurse, is it possible to sort of like upskill?
Yeah. So actually, the amount of time that it takes for what I'm doing is 0.5 of a full-time position. And on the South Shore, we deliver around 360 babies, like one a day type of thing. And I've been able to support 25% of that at the most. Who has a calculator? 25% of 360 is what I'm able to support in a part-time position. And so you would just have to scale up or down depending on your site. Yeah.
Okay, thank you.
Yeah.
I'm in a role with Nova Scotia Health right now. We're kind of interested in implementing similar navigators for other conditions, and
Oh, okay.
I think yeah, like if you were to publish this work, I think it would be great justification for having more of these mental health navigators, but also for other navigators or vice versa, like the work that comes out, it might help
Yeah.
justify more support for perinatal mental health nursing. And I know that's something they always want to know is like how many FTEs, how many patients
Yeah.
that serves. So
What's the cost?
yeah.
Yeah,
Thank you.
absolutely.
And 25% is probably not even close to what the need is, right? I mean, you have a sense of what the
Yeah.
need is.
It's as many people that have been identified and offered referral, essentially.
Mhm.
So I haven't had
Yeah.
to decline anybody, but yeah, when we look at like total anxiety rates, that's people identifying it. So they could already be treated. They could actually have it like well managed. But
Mhm.
yeah,
Yeah.
yeah.
Well, maybe I'll reach out to you separately, Crystal, because I think there are some faculty that might be helpful to connect with that might help you with the journey of publishing.
Amazing.
Because I think, well, I think it's so important. The work you're doing and how you got to where you are is so important, that it needs to be out there. And I think it to be out there so that it gets its full recognition that it deserves. So it is an official role, and it becomes the norm, and other navigators can be put into place and or considered. So I'll email you after
Thank
and give
you.
you some suggestions. But thank you so much. Very important work that you're doing, and I'm so proud that you're in our program. I really do. And I'd love to showcase that. I think that's fantastic. So thank you again for your presentation.
Thank you.
I'm going to stop recording, but I did put a link to our survey for people who've been in the audience to find out how useful these sessions are and what they would like moving forward. So if anybody could fill it in, we'd appreciate it.
Thank you. And my referral form is right there. So let's just make sure that's the right one. Can everybody see the referral form there in the chat? Yep, that's the right one. Okay, perfect. Yeah, so Gail, if do you have it there? Did you get it? Are you able to open it?
I do not see it.
You don't see it in the
It's
chat?
just in the
Oh,
chat.
it says failed to send. Okay, so
Oh,
I will
okay.
send it to you separately.
Okay.
Yeah,
I wrote down your
Crystal,
name so I can email you.
okay.
can you put your email in the
Yes.
chat? Thank you.
Yeah. There you go.
Thank you.
All right.
Great.
Thanks so much.
Thanks so much.
Thank
Bye-bye.
you.
Bye.
Bye.
Thank you.